Good day, everybody. This is Chris, the Ancient Scholar, and I'm back again. And the next class of antidepressants that I want to talk about are the so-called tricyclic or cyclic antidepressants. These are often referred to as the TCAs, also known as the tricyclic or cyclic antidepressants, or tricyclic, however you want to announce that. All right, and these work in somewhat of a similar fashion to the SSRIs, the selective serotonin reuptake inhibitors. These are much older. These actually came into clinical practice in the 1950s. They're very effective at what they do, but as you guys are going to learn, or going to review, the side effects profile, particularly in the setting of overdose, is pretty substantial with these particular agents. So these do work in a sense like the SSRIs in that they do inhibit serotonin or 5-hydroxytryptamine reuptake. However, they also inhibit the reuptake of norepinephrine. And norepinephrine, of course, has different effects as a centrally acting neurotransmitter than it does a peripherally acting neurotransmitter as a catecholamine. Serotonin is technically considered a catecholamine as well, or some people do. And as you might imagine, the indications for tricyclics are very similar to that as the SSRIs. So the indications are also very similar in that we use these to treat depression, anxiety, just mood disorders in general. In addition to that, these seem to have a role in modulating pain, particularly chronic neuropathic pain. So these are often used to help treat people with, say, chronic back pain. They have sciatica, or they have a lot of radicular signs and symptoms. The TCAs may be used to help treat these particular patients. Okay, so I just have a picture, a diagram of a TCA, and I believe this is a mipramine, but it has a very similar chemical characteristics to some of the most common tricyclic antidepressants, imipramine being kind of like the classic one that we can talk about, although amitriptyline, also known as Elavil, and nortriptyline are perhaps fairly common, or more commonly encountered in a clinical context. So as you can see, this has the three-ring structure here. You've got these benzene rings. You've got a ring in the middle here, and you have a nitrogen atom, and then you've got this little carbon bridge here that connects to an amine group here. And this is this particular molecule belongs to a class of tricyclics or TCAs known as the tertiary amines, because here you have your nitrogen, and instead of the NH3 molecule, which is ammonia, the three hydrogens are replaced by other groups. You've got a methyl group here, a methyl group here, and then this nitrogen's attached to carbon here, hence the term a tertiary amine. That's not necessarily as important as these aromatic rings here. And whenever you have lots of pi bonds and you have aromatic rings, that really makes for a highly lipophilic molecule, and so these molecules can penetrate into the brain fairly easily. And under certain circumstances, and that'll become relevant clinically, these molecules can be highly protein bound as well. So you can change the physiological conditions within the human body, and you can enhance the capacity for these molecules to undergo protein binding. So the fact that they're innately lipophilic and the fact that they can become more protein bound depending on the physiochemical conditions of the patient is very relevant when it comes to treating tricyclic antidepressant toxicity. Okay, so what I want to do is I want to talk about some of the additional things that we see. So obviously we can have kind of a serotonergic kind of picture with the tricyclics, but that's not really makes these nasty. And so let's talk about some of the additional effects that we see with the TCAs, because these are very notable and they are very important when we talk about some of the classic signs and symptoms, particularly in an overdose concept. So the first thing that I want to note is that these are very good at antagonizing acetylcholine receptors. So these are anticholinergic and exert anticholinergic effects. Specifically, they're very good at antagonizing muscarinic receptors, both peripherally and centrally. And so this can lead to more classic anticholinergic effects. And they can also cause altered level of consciousness, and they can be rather sedating as well as some of the anticholinergic antihistamine kinds of drugs that are out there, say Benadryl, diphenhydramine. In addition to that, the TCAs are very good at antagonizing peripheral alpha-1 receptors. And if you remember, alpha-1 receptors are primarily, peripheral alpha-1 receptors at least, are primarily located in vascular smooth muscle. So these are very good at causing vasodilation and ultimately can cause a decrease in blood pressure. So you get some anticholinergic effects where you get an increase in heart rate, you get altered level of consciousness, but then you can get a decrease in blood pressure due to the peripheral alpha-1 antagonizing effects. In addition, these do block histamine, so these functionally act as antihistamines. And this can in part also lead to altered mental status, the tiredness, lethargy, sedation that you can get. And perhaps the most significant effect that the TCAs have is that they're very good at blocking fast sodium channels. So they can block fast sodium channels. And these functionally act like class 1, particularly like the class 1A antidysrhythmics, if you remember reviewing the class 1A antidysrhythmics. And so what do these do? These prolong the duration of the cardiac action potential, particularly in ventricular tissues, and that, of course, widens the QRS, increases the QT interval, which subsequently increases the risk for, say, torsade de pointe, polymorphic ventricular tachycardia. In addition to that, you get some negative inotropic effects, right? So the heart does not contract as effectively, and you get negative dromotropic effects. You slow the speed of conduction through the ventricles, and of course that clinically presents as a widened QRS. And because you get an increase in heart rate due to anticholinergic effects, you tend to develop a wide QRS tachycardia with substantial tricyclic antidepressant toxicity. And this obviously will potentially manifest as ventricular tachycardia and possibly torsade de pointe. These are both very critical dysrhythmias that can develop. And so that's something that we need to really look out for. So in the context of an overdose, what we primarily see is we get altered mental status, we get a wide complex tachycardia, we get hypotension, and in substantial cases we can get an increase due to the sodium toxicity. We can get seizures that can develop as well. So all in all, a pretty nasty kind of overdose. So there's significant morbidity and mortality, and it's primarily related to this right here. The sodium channel blockade is where most of the morbidity and mortality from these, and these are sometimes referred to as one pill can kill agents, particularly in the setting of pediatric patients or elderly patients who may have compromised hepatic and renal function to begin with. Taking one or two extra pills may result in substantial morbidity and mortality. So with that in mind, let's just talk about the primary treatment. How do we manage these patients? Because there are some specific treatment considerations that we need to think about. So first and foremost, with the widened QRS, right? These patients are presenting with a wide QRS tachycardia. It's generally a QRS complex greater than 0.12 seconds. It is recommended the primary pharmaceutical treatment is sodium bicarbonate, and we tend to recommend 1 to 2 milliequivalent per kilogram IV/IO bolus, and we can give that every 3 to 5 minutes to reverse the problems. And we just look at the QRS complex, watch for it to narrow. If we can get arterial blood gases, that's good to monitor, and we tend to recommend you want to target your pH, and you don't want your pH keep the pH under 7.5. So you can get the patient fairly alkaline, but you don't want their pH to go above 7.5. And so that would be the primary treatment. Give them some sodium load. And in addition to that, the alkalinization effect on their serum may enhance protein binding. And remember, I mentioned that up here, that if we change the physiochemical environment of the patient, we can enhance protein binding. And so making the patient a little alkaline can enhance protein binding, and that will mean that the TCA, the tricyclic molecule, will have a higher affinity for blood proteins such as albumin, and instead of a high affinity for, sodium channels, fast sodium channels in the heart and in the brain. So you're actually fighting this overdose on two fronts with sodium bicarbonate. It's a very important thing. Okay, additionally, if the patient does develop ventricular tachycardia or torsade de pointe, you could also consider magnesium sulfate, particularly with torsade de pointe. In conjunction with, of course, sodium bicarbonate. If the patient develops hypotension, primarily due to alpha blockade, initially, just like most types of hypotension, initially we want to make sure that there aren't any fluid volume problems, so isotonic fluids, isotonic bolus. And if the patient does not respond to that, then an agent that's very good at agonizing alpha receptors would be considered, and more than likely norepinephrine is going to be your agent of choice because it has high affinity for alpha-1 receptors. It's primarily an alpha-1 agent. So if there's no response to an isotonic fluid challenge, go ahead and look at giving this patient norepinephrine. Okay, another thing can happen is if the patient does have seizures. Of course, benzodiazepines are going to take front and center as they always do with most types of seizure therapy, or at least initial seizure therapy. Okay, so let's say that I have a moribund patient and they're refractory to all the standard therapy we've talked about. They're moribund, they're dying, they're very sick. What can we consider? And I don't know that there is a substantial amount of evidence here, but from a physiological, physiochemical argument, you might be able to argue this, and there are some case reports out there that suggest this is helpful in certain populations, and that is, again, lipid rescue. Because these agents are so lipophilic, lipid rescue, 20% intralipid, may actually be helpful in certain circumstances. It may act as a lipid sink, or possibly through other metabolic mechanisms that I won't really get into in this particular video, but maybe if people are really interested in lipid rescue, we can talk about that in some more detail. In fact, I think I have on prior videos, but lipid rescue may be an option. In addition to that, if we are in a setting that does this, more extracorporeal methods could be considered, such as ECMO, extracorporeal membrane oxygenation, or cardiopulmonary bypass. And just as a final note, we would not treat the wide complex tachycardia like we would in a standard or more standard patient who is presenting with VTAC or something that is a wide complex tachycardia, and that is to say that we do not treat these patients with class 1A, class 1A agents, class 1C agents, or class 3 agents. So that would include things such as procainamide or amiodarone. That would potentially exacerbate the underlying situation because all three cases, the 1A, the 1C, and the class 3 agents, they all work very similar to the classic class 1 agent, and they prolong the action potential. Or in the case of amiodarone, it prolongs not the action potential per se, but rather it prolongs repolarization, which still impacts the QRS complex to some extent, and ultimately the QT interval. And so it prolongs the QT interval and increases the risk for torsades and polymorphic VT, which is certainly not a good thing to have. So these particular agents are highly pro-arrhythmogenic in the setting of tricyclic antidepressant overdose. So just to sum things up, tricyclic antidepressants are really nasty, and they have multiple additional side effects. Some due to anticholinergic activity, peripheral alpha-1 blockade, histamine inhibition, and most importantly, the ability to block fast sodium channels, and that's where the significant morbidity and mortality is associated with this sodium channel blockade. Pharmaceutically, sodium bicarbonate is going to be the classical agent that we use. We can consider magnesium sulfate for torsades, isotonic crystalloids followed by norepinephrine if needed for hypotension, benzodiazepines for seizures, and in moribund or refractory patients we can consider lipid rescue or extracorporeal methods of rescuing this patient. And that's mainly it as far as the major pre-hospital implications for the tricyclic antidepressants. All right, hopefully you guys enjoyed that, and we'll see you again on the next video. Take care. Bye-bye.